Good afternoon from Ghana to everybody, wherever you are joining us from, and welcome to our webinar on improving follow-up and retention in clinical trials, perspectives from trial sites in Ghana. And this webinar is brought to you by the Global Health and Infectious Diseases Research Group at the Amuasi Center for Collaborative Research in Ghana, and the Global Health Network, which is based at the University of Oxford. Now, we convened this webinar to delve into the critical issue of participant retention in clinical trials. I think we all know this is a challenge that impacts clinical research outcomes globally. So today, our agenda will span an examination of this issue and a discussion of some contextually appropriate retention strategies. We are focusing mainly on insights from trial sites in Ghana, although we believe these will be applicable to other LMIC and really many other contexts, actually. So we just have about an hour and a half to do this. So it's quite a limited time for all the ideas and thoughts we want to share with you. But during the short period, we aim to spotlight some of the key challenges within this dynamic and discuss some practical approaches which are relevant to our context. Additionally, we would also like to learn from your own experience, how your trials and even observational studies actually, because the question of retention is important, whether you are doing a clinical trial or an observational study. Overall, the goal is that we will foster knowledge exchange and inspire future improvements in clinical trial practice. So we thank you very much for joining us today. So by way of introduction, my name is Melvin Agbogbatey. I'm a clinician infectious diseases, implementation research on communicable diseases, as well as non-communicable diseases, snakebite and venom, among others. So I'm delighted really to be joined today by four eminent panelists in the presence of Dr. John Amuasi, Dr. Seyram Kaali, Mr. Oscar Bangre, and Mr. Jonathan Gmanyami. I intend to introduce them a bit more in depth before they speak, so that is sure to follow. So I will go on to the housekeeping at this point. And so first, we are going to record this session. The recording has actually started. We will also share the recording in the coming weeks on the Global Health Network's YouTube channel, so you can review that and further share the material if you wish. The link to this channel will be put in the chat, so you can also save this for later. You will be able to use the chat feature, as you can see on your screen, to introduce yourself if you wish, or to report any technical issues you might be experiencing. And you can interact with the panelists using the Q&A feature to post your questions, comments. You can even post anonymously if you wish. Because of the size of the call, your cameras and microphones have been muted by default. But when we get to the point where you are able to raise your hands and ask questions, we'll be able to enable you to do this. So we have a dedicated Q&A time at the end, so we can take your questions at the end. But surely you can type in your questions dynamically as we go in. Okay, great. I think I've covered the essentials, so we'll get straight into the thick of affairs for today. And I'll be introducing the first speaker, who's in the person of Dr. John Amuasi. And he'll be speaking on the topic of clinical trials and the problem of attrition. So Dr. Amuasi heads the Global Health Department at the Kwame Nkrumah University of Science and Technology in Ghana. He holds a W2 professorship and is group leader of the Global One Health Research Group at the Bernard Nock Institute for Tropical Medicine in Hamburg, Germany, and also at the Amuasi Center for Collaborative Research in Tropical Medicine, which is here in Ghana. Dr. Amuasi's research involves both field epidemiologic and clinical studies, including clinical trials across Africa on emerging and re-emerging infectious diseases, antimicrobial resistance, and NTDs, including snakebite and venom, just to mention a few. John is also co-chair of the Lancet One Health Commission and an honorary visiting research fellow at the Nuffield Department of Medicine at the Oxford University. So thank you very much for accepting to speak to us today, John. You have the floor, please.
Thank you very much, Melvin. I'll jump straight into it. Attrition What is attrition? I'll start by saying it is basically a dropout or a withdrawal from participation in studies, for that matter. And what causes this is an unequal loss of study participants. Now, so important in clinical trials, and I'll come to specifically why attrition is important in clinical trials, but bearing in mind the fact that people who elect to participate in clinical trials are always given or should always be given in line with GCP the opportunity to withdraw. Now, the question is, why would they choose to withdraw after having agreed to participate, and what is the implication of this withdrawal for the study? A bunch of reasons why attrition can happen due to unsatisfactory treatment efficacy, intolerable adverse events, or even death. Let's say that participants in a trial hear that one participant has suffered an SAE, i.e. death, be it unrelated to the trial. It may be a negative motivation for them to say, I do not want to participate anymore. Also, those who do not comply with the treatment schedule are more likely to be excluded from the study due to a violation of study protocol. So what's going to happen is that these are going to be taken out or removed. So we'll put it quote unquote, they have removed themselves, more or less they suffered a technical knockout from the trial. So let's look at just a general schematic regarding this whole attrition argument. We're starting with, this is your eligible sample. You have your sample of people who are arguably eligible to participate in your study, and you're going to have some either going to receive treatment or going to receive the intervention. I'm talking generically, not necessarily within the context of clinical trials. So we call this a program group. And then you'll have another group, which you'll call your control group. Your argument, as always in experimental study designs, is that your experimental group or your intervention group and your control group are the same. And the only difference between the two is going to be your intervention. And so you are supposed to be in a good position to compare the two, with the argument being that any difference seen between your program group and your control group is a function of your intervention. This is the assumption, right? You want to produce similar groups. So this is what you get. And when attrition occurs, the bottom line is that the program and control groups are no longer balanced. And then this becomes a problem. And on the left-hand side, you would see an example of how attrition could happen as a result of a respondent not responding, or someone not responding to a follow-up survey. So when that happens, you would realize that although you have an attrition of -1 in both the program and the control group, the underlying motivation for being removed from the group is different between the two. And this poses a problem. It shakes the very foundation of the experimental study design, i.e. lack of comparability between your intervention or program group in this context and your control group. So what are some of the other factors that can contribute to patient attrition? Basic underlying factors like age, sex, gender, race, and so on and so forth. Even willingness to participate fully, it can be one. And this is why we try to control for all these, especially right at the outset in the study design stage, to make sure that age, sex, and gender, race, and so forth do not contribute unduly to this. And this is why stratification is one of the most elegant ways of addressing some of these risks at a very high level, right at the beginning. So you sample, say, males and females separately, as opposed to just randomly sampling the population and hoping for a balance in sex or in gender. Socioeconomic factors, very clear. This is a really tricky one. We know as researchers how socioeconomic status can affect attrition, especially for clinical trials where sometimes you're mandated to dish out what might otherwise be viewed as juicy compensation packages. I mean, what does 500 Ghana cedis mean to Dr. Agbogbatey? I mean, he might not even recognize this, but 500 cedis to someone of low socioeconomic status might be a big deal. And I mean, let's face it, we're seeing situations where in clinical trials we recruit somebody eligible and the person comes with several others. And we know very well the motivation here is the compensation, and it's a big deal to all of them. People even make quote unquote small business out of recruitment simply because of compensation packages. But now, if this quote unquote snowball approach to recruitment, and take note, it doesn't challenge the eligibility criteria, is a function of socioeconomic status, then there's a risk of attrition following a certain pattern. And when it gets out of hand, then that can have implications or biases for your study. And we'll get there very soon. The informed consent process in itself, but some people, by the time you're done informing them, they're like, look, this is way too much. And, the way you're talking plenty, there must be something really critical here I'm missing. And the way you're warning me that blah, 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 and blah. Look, let me just go somewhere and not really get into this study that you're talking about. Just too much for me. All right. So it's always a delicate balance between providing all the information as transparently as possible, but also in a coherent, comprehensible way that doesn't confuse the potential participant and allow for refusal or later attrition. The study protocol itself could be very demanding. How can you keep things as simple as possible to reduce the risk of attrition? You're asking the person to come in every third day for one thing or the other. At a point, the person says, look, I've collected enough of your compensation. I'm quite happy. I've achieved my financial objective. I'm out of this. But then it's a problem for you. And so then the obvious untoward side effects. And of course, in trials, you can have some surprise really untoward effects that can affect attrition. And sometimes when people notice their colleagues suffering one thing or the other, they're motivated to chicken out. And then lack of patient or community involvement as partners in the research process. This is critical because then when one thing goes wrong, it trickles a cascade of withdrawals, i.e. attrition, which may just be a function of people's concern based on what one otherwise viewed as credible witness might be sharing. And so when you engage a community at the right level and in the right way, your risk of all this is minimized. So this is just a graph from a study which was published in 2022 showing the different factors that could account for attrition and how these play out. So on the y-axis, you have the proportion of respondents reporting, and then you have a factor such as on the far left, if usual care was not covered by insurance, and then you see how the degree to which that influenced consideration for participation. And you can see that insurance coverage is a big factor. What if the person receiving payment for participation? Of course, this work, I can't remember very well where it was conducted, but you can see how it's almost pretty even. It is definitely a factor, but seems not to be so much of a factor in terms of comparing the a lot to somewhat a little and not at all, and whether they're going to receive support for participation. But you can see to all intents and purposes that insurance coverage was perhaps one of the greatest factors. This is another paper that was published also 2022, looking at participation in and withdrawal from a cancer clinical trial, surveying clinical research coordinators. And you can see, again, I need to go a bit faster, on the top graph, the various concerns that were raised. And you can see above all concerns about adverse events really topping the charts, as opposed to challenges in the process of obtaining consent as a major issue, and lack of understanding, again, topping the charts, again, pointing to the need for very clear, informed consent processes and making sure that potential participants understand. Again, these attrition rates vary not only across study types, as you see in this selection of papers, but also across study settings. In this review of about 18 palliative oncology clinical trials, we saw an attrition rate of 26% for the primary endpoint and 44% for the end of the study. What that means is that as you progress, so there's a correlation between attrition rate and length of study, i.e., the longer the study, the greater the attrition rate. And you can see also a systematic review of randomized controlled trials showed that clinical trial dropout rates could vary from 4% to 71%. So this really varies across study types and across study settings. Also, you can see differential attrition between the intervention arm and the control arm. And this is what you really don't want to see at all. You really don't want to see this. If for anything at all, you want the attrition rates to be even between the arms. Especially if it's a double-blinded study. Of course, sometimes you may not know this until the very end, and then it can produce it's kind of a challenge for you in your analysis. So overall, the odds of withdrawal were lower in the experimental arm compared to the control arm, and albeit not being significant per se, which is good, but because you really don't want any difference between the two. Again, some studies have investigated hypothesized effects of individual characteristics on attrition. And you remember in my earlier slides, I talked about basic things like age, sex, and other constitutional factors and how they impact. But this study showing that neither age nor sex was significantly associated with attrition, which is great. But comorbidity count was associated with trial attrition. I guess this is pretty intuitive in the sense that if people have comorbidities, it's more likely to be laborious for them to keep on coming and keep on engaging, and the risk of they dropping out is higher, unless, of course, you are doing a trial of some wonder drug for which they're seeing marvelous results, and then those with the comorbidities might be more motivated to stay in with you. And here again, you see a paper on early participant attrition from clinical trials and the role of design and logistics. So as I was saying earlier, the way you go about designing your study right from the outset has implications. Even screening duration has a significant impact on that. Some screenings can be so painful. By the time people are done with the screen, I'm like, look, even if this is just the beginning, I'm not ready to continue this journey with you. I can only imagine what's coming next, right? Then there's also the issue of race, and minorities can also play a big role. And in this study, you saw that in this case, comparison between blacks and whites, and a significant adjusted odds ratio difference, with the reference being the whites, i.e. the attrition rates in the minority was much higher. And then educational level also playing a role. I just need to go a bit faster. But why is it so important in clinical trials? In clinical trials, you're really trying to arrive at conclusions regarding the treatment effect. And if you are getting this wrong, it has implications for policy regarding adoption of therapeutics, dosing of therapeutics, clinical treatment guidelines, and so on. So it could be highly problematic. And these rates of attrition in clinical trials vary, and the local data is very rare. So it's really hard to understand what the impact is on clinical trials. But your statistical power can be affected, as I was explaining to you. Unfortunately, if it's your classic double-blinded clinical trial, you will only know the impact of attrition when you are done, especially if you have a difference between the intervention arm and the control arm. Then you may have to find some statistical approaches to addressing any biases. Again, generalizability becomes a problem. And if you're a trial, I don't know any trial that's cheap, but if at the end of the day, because of attrition, all you have is nonsense, then it's a big loss to everybody in terms of the knowledge generation. Then moving forward, how your results will be viewed to impact policy, as I mentioned earlier. I will skip this for now, but just to show you that attrition can have a huge financial impact. And just estimates of attrition can also impact on choice of sample size, which has implications for cost of study, duration of study, and so on. So even the known attrition rates can impact on what your expected sample size is supposed to be, aside your classic sample size calculation parameters. So what do we take away from this? We expect attrition. We know it will happen. If we understand all the flexure points, then we can address them right from the study design stage through to the end and hopefully minimize attrition. We do not have concrete data on how attrition works in Ghana. It'll be very interesting, and I throw this challenge to the Kintampo Research Center, which is one of the leading clinical trial centers. Kaali is smiling, I see. But to bring together your data, we'll add a few drops here and there. Maybe we get the Navrongo folks and Adodoa people. Let's just see what is our attrition rate for trials in Ghana. I think nobody has done this before. It could be very interesting. It's very low-hanging fruit right there. So I present to you, Kaali, this low-hanging fruit for plucking. And of course, we just want to find a way of lowering this attrition overall so we can have more reliable data. So with that, I want to say thank you very much. I apologize once again for the challenges that we had in the beginning in sharing the slides. Back to you, Melvin.
Thank you very much, John. No problem at all. We did have some technical hitches from the beginning, so the time lapse is understandable. I will invite Dr. Kaali to start sharing his slides very soon. But just one question from one of the participants I want to throw to you, John, which you can answer in a few seconds, and I'll hold you to that. So his question is, in certain conditions, attrition rates can be high, between 30 to 40%. Is it worth factoring such high values when estimating sample size to execute a trial, or should the trial be abandoned? This is his question.
No, very good question. I think I invariably answered this in my last couple of submissions. What I'll say is that it all depends on, how much time and how much money you have. Because if you know what the estimated attrition rates are, you factor that into your sample size calculation. What that means, it's more time and more money you're going to spend. If you have it, good for you. But if you don't, and you do your cost effectiveness analysis, or should I say cost benefit analysis, and you realize, look, it's not worth it having to increase your sample size by 30, 40% simply to achieve. And I mean, for some trials, especially when remuneration is based on successful completion, you do the math and it just doesn't add up, then it becomes not worth it, unfortunately. But this also brings into question the approach towards running trials, including remuneration schemes and arrangements, because you could easily bungle or total a trial simply because it's not cost beneficial. Meanwhile, the knowledge to be generated is so critical. So I think this just raises or opens up a whole Pandora box of the approach towards conducting trials, especially in places where you cannot control high attrition rates, or you want to make sure that attrition doesn't end up making nonsense of the trial simply because you did not take it into consideration right from the beginning. I'll stop there.
Thank you very much, John, for the answer. I've seen a few hands up, but unfortunately, we can't take any questions at this point. I'll invite you to put your questions in the chat box, and then we'll do our to answer them during the Q&A session, or we'll type them in. John will type some of the answers in as we go along. So as I invite Dr. Kaali to start sharing his slide, he will be taking us for the next topic, which is on insights for enhancing retention in clinical trials. I must add quickly that Dr. Kaali will be leaving shortly after his presentation. So for him, we'll dedicate maybe a couple of more minutes so he can answer questions before he leaves. But Dr. Kaali is a clinical research fellow and physician scientist at the Kintampo Health Research Center in Ghana. And this is a research center that is under the Ghana Health Service. He is an expert in clinical trials with over 10 years experience in phase 1 to 4 clinical trials in therapeutic areas such as malaria, Lassa fever, COVID-19, and sickle cell disease. He currently leads the clinical research group at the center. He also has a strong background in environmental epidemiology, with particular interest in understanding and preventing the early life effects of household air pollution, particularly those related to cardiovascular and chronic respiratory risk development. His research focuses on prenatal and early childhood air pollution exposure and cardiovascular and respiratory disease risk settings. Dr. Kaali obtained his medical degree from the Kwame Nkrumah University of Science and Technology. He joined the research center in 2013 and went on to obtain his master's in public health from the London School of Hygiene and Tropical Medicine in 2017. He's currently studying for his PhD in epidemiology at the Swiss Tropical and Public Health Institute in Basel, Switzerland. Thank you very much, Dr. Kaali, for joining us this afternoon. Over to you.
Okay, so thank you, Melvin, for that introduction, and very glad to be part of this webinar. So John has done a very good job laying the foundations for what I'm going to talk about, so that makes things easy for me. So I'm just going to give a brief overview of retention in clinical trials, and then we'll talk about factors contributing to poor retention, and I'll share with you some strategies that we've used at Kintampo to try to improve retention in clinical trials. So retention can be broadly defined as the strategies and tactics that are designed to keep participants enrolled in a trial and prevent attrition or dropout, as we heard from the previous speaker. And dropout from trials, from observational studies, can result from consent withdrawal. So participants have the right to withdraw their consent anytime in the course of the study. Can be due to loss of follow-up during the follow-up phase. And in rare instances, investigators also exercise their discretion to withdraw a participant depending on specific circumstances. So just a brief overview of the problem of retention. We had details of this in the previous presentation. So when we design studies, clinical studies, observational studies, there's a truth in the universe that we want to uncover. And so we pose research questions. We formulate a study plan to try to answer the research questions. And then we sample, we have a study sample from a target population. And then we conduct our study, and at the end of the study, you end up with the actual number of participants that you took measurements on. And then from these measurements, from these participants, you're going to make inferences about what happened in the study, and also what the truth in the universe is. So you can see that if at the end of the study, the measurements that you have, or the participants that you have, are different from those that you started the study with, or from the population from which the sample was taken, then that threatens the sort of inferences that you can make from your study. Loss to follow up can threaten the internal and external validity of a study, and dropouts can be differential or non-differential. So in the context of randomized controlled trials, where we have two or more groups, so you have an intervention group, you have a control group, you know, if the dropout is such that it is related to an outcome, an endpoint in the study. So for example, you're running a sickle cell trial where participants are experiencing adverse events for some reason. So you may not know this, as the investigator, if this adverse events that they're experiencing is due to the active medication, then you're going to have participants in that group who will have, be dropping out. And so at the end of the study, you're going to end up with differential dropout rate. And then that biases the results from your study. So you can also have it in a non-differential manner, where attrition is fairly equal between the study groups. Yeah, so that is also a problem, because that can lead to an underestimation of the treatment effect. So let's look at some of the factors that contribute to poor retention. So this is also related to factors that contribute to attrition, right? But here, I'm sharing with you from my experiences in Kintampo some of the things that we've seen as contributing to loss to follow-up or dropouts or poor retention. And I've tried to categorize this or classify this into participant factors, investigator or site factors, and study design factors. Although in real world, some of these are cross-cutting, right? But just for simplicity's sake. So for study participants, so adverse events can be a reason, when participants experience adverse events, word goes out very quickly. Rumors spread very quickly, among study participants. And so for fear of experiencing adverse events, they may decide to not come back to the study clinic. So still on participant factors, might be due to relocation. So after enrolling, some participants might move. But this is why it's important to enroll participants who are going to stay in the study area for the duration of the study. And some participants, they simply lose interest, okay? And unfortunately, you can also lose participants in the course of a study. So let's look at the investigator or site-related factors. So if you have a site that is difficult to reach or access, then that can be a problem for participants. If participants have to go through difficulties in attending study visits, appearing for study visits, and you don't put in place any interventions to try to make it easy for them, they will just not come. Unresponsiveness to participant consents. Yeah, so that can be another factor. So we have to create that environment where we respond to all the issues that participants may have to keep them in the study. Inadequate community engagement. So this is crucial and cannot be overemphasized. It is important that before we conduct any study, we adequately engage the communities in which we are going to conduct the study. And this is especially important in our setting. I mean, in Ghana, and I'm sure in most sites across Africa, there are important stakeholders. The decision to participate in the study and remain in a study is not just one, the participant's decision. It can also depend on so many other people, in a hierarchical society. And so we need to take cognizance of that fact. Also, inadequate healthcare for participants experiencing adverse events. So we saw that in one of the papers that John presented. So if you're conducting a trial and you're just interested in collecting data, doing your study procedures, and then that's it. You don't facilitate routine care for your participant. That can be something that they can become embittered about and decide to just drop out. Inadequate consenting. So consenting is very important, and I'll talk about this later into more detail. Inadequate compensation, lack of trust between the study participants and the study team. Okay, so let's look at the study design factors. So complex and burdensome protocols, long follow-up period. So as we saw, attrition is a function of the study duration, right? So if you have a very long study duration, or if you have a study that is so burdensome, you have to try to reduce the burden on participants at the design phase. Okay, so moving on now, let's look at some of the strategies that you can put in place to try to improve retention. So number one, community buy-in. So try to get community buy-in by doing proper community engagement. So before the study starts and after you've obtained approvals, all the necessary approvals, so you make sure that you make a list of all the relevant stakeholders. And in our setting, these can include local political leaders, traditional leaders, religious leaders, healthcare professionals. So there are some healthcare professionals who might even discourage potential participants from joining your study. You know, some people know a little about clinical trials, but not enough, you know, to give good advice to their patients. They may pollute the minds of such participants and discourage them from joining your study. They may scare them that, you know, if you join this study, you have adverse events and this and this and that. Yeah. So it's important to identify all these groups and also patient groups. So now we have some patient groups coming up. It's important to engage those people to try to gain their trust, to try to be part of their community, their activities, so that it helps, if you want to recruit and you want to keep them in your study. Okay, so moving on to the second strategy is consenting. So consenting is crucial. As I mentioned earlier, it's important that participants understand what they are in for. So participants should know about their rights and the right to withdraw at any time without consequence to them and all that. But they should also be made aware of their responsibilities and their obligations, right? So if you accept to join a study, you should attend all the study visits. Your consent, you're saying that, okay, I commit to attend all the study visits. So that should be made clear to participants at the outset. And consenting is a process, right? So it's not just a one-time event, and it starts from the pre-consenting phase. So at a stage where you are looking for participants to join your study, where you're briefing them about the study and inquiring about their willingness to participate. And then the main consenting, where you conduct a detailed consenting before conducting any study procedures. And in the follow-up phase, anytime you come into contact with participants, you make contact with them, it's an opportunity to try to reiterate certain aspects of the study and then respond to any concerns that your participants may have. Okay, so providing adequate care. So it's crucial in our setting that we make provisions to at least facilitate care, for participants, so especially in studies where the therapeutic area is say chronic disease, say a sickle cell disease trial. The routine care has to continue. So you're not just there to do your study procedures and collect your data, but you should also facilitate routine care. Make sure that the participants are attending the clinic, they are receiving their folic acid and all the things that has to be done for them. Make sure that they are getting that. So try to reduce the barriers to care seeking if they have an adverse event and they go to the hospital and they have to join a very long queue. One of the advantages of being in a trial is that the study team should be able to break those barriers so that the participants do not have to wait for so long before they can access care. And it's also reassuring from time to time to have participants, to have senior clinicians, specialists attend to participants. It makes them feel a part of the team. So now let's look at a study design. So where we have to try to simplify complex designs, right at the design phase. So sponsors should engage sites during protocol development, and they should be flexible to inputs from sites. And there are things that we can do to try to reduce the burden on participants. So, for example, certain sites are set up such that the study clinic is in one side, and you have the pharmacy, you have the lab in another part of the compound of the site, right? And you have to get participants to move from one place to the next, all because of your study. So if that happens, you're stressing them, and it may get to a point where they will decide to just drop out. So in this case, it will be prudent to try to centralize your study procedures in one place. Try to have one place, a study clinic, where as much as possible, everything is done, from questionnaire administration to clinical procedures, vital signs, and sample collection, and drug administration in one place. And it's also important to create a congenial atmosphere. So treat your participants with respect. So understand that these are people who also have their own lives to live. They have their own schedules, right? So don't just call the participant today, Madam Grace, you have a study visit tomorrow. You have to be at the study clinic tomorrow. No, let's try to make contact with them way ahead of time, and then build consensus with them. I mean, most scheduled visits come with some, window around the expected date of visits, right? So you should start contacting the participants ahead of this window, and then decide with the participant when it is best for them to come to the clinic for their study visits. Be flexible. We should be willing to conduct certain visits in the community, in participants' homes. So if the participants' schedule is such that they cannot come to the study clinic, and you can perform your study procedures, in a private place, in the community, in their homes, why not just go to them? Don't always expect them to come to you. Okay. All right. So communication. Next one is communication. That's very important. So at the start of the study, you have to devise appropriate communication strategies to continually engage your participants. So for example, if you have like a long period between successive visits, like 1 month or 2 months or 3 months or 6 months, and you've not heard from your participants because the next visit is in 6 months' time. The 6 months will come and you will not know where that participant is. So from time to time, you should call them. You can pay them visit. Study team, study coordinator can visit them, or field team, field workers can visit them, check on them, and all that. And also, it's important to communicate the results of all study-related procedures and tests. So they are participants, they are partners, they are participating in the trial. with us. They're not just subjects on whom we are just collecting data. So there should always be that communication with them. Always tell them what their test results show. Provide feedback after every visit, and take feedback from participants. The PI should be reachable, and coordinator, it should be reachable by phone around the clock, so that participants can, if they have any issues, they can easily reach you. If participants, they can't get to the PI for much of the study duration, they don't feel that they are part of a process. Okay, so now let's look at some of the participant-related strategies. So we can have appointment reminders. We spoke about this in the previous slides. So send them appointment reminders about their visit, about their scheduled visit, a phone call, it can be text messages, remind them, prepare them ahead of time, provide ethically approved reimbursement and compensations in a timely manner. Okay, so participants come for the visit, and then it takes like a week or two before they get the reimbursement for travel costs. If that happens, it breeds a lot of discontent. And then there should also be ongoing health education about participants' condition, right? So that we don't appear as though we are just interested in collecting data, but continue to advise, provide education about how participants can stay healthy along the trial. So I have just a couple of slides left. Just wanted to talk about some visit scheduling tools that we can use so that we don't depend on our memories to schedule participants for visits. I mean, you can use simple tools. You can just have a spreadsheet and then draw up a calendar for your participant. Once a participant is randomized, you draw up a calendar. You know exactly when they are coming for which follow-up visits. You could also use web programs like Suvoda. So this is one program that we use after randomization. It just populates for you the dates for all the follow-up visits. And you can enhance this by building in some features where the program can send you automated email or messages, reminders, to the study team as well as to the participants. So I'll end by talking very briefly about some examples from KHRC, showing you some of the trials that we've conducted over the years and the retention rate. So it varies, and retention rate also depends. It's also a function of the trial design in terms of the number recruited, the length of follow-up, and all that. So so as you see with this RCSS phase 4 study, so we are getting a retention rate of around 90%. That's because the number involved is so huge, right? But if you come down to a phase 1 study, for instance, where we recruited only 18 participants, we were able to keep all of the study participants in the study for the follow-up duration of 12 months for each participant. And yeah, I mean, generally, you would want to see such high retention rates. Not that I've cherry-picked the studies with high retention rates, but I mean, our goal is to set a very high goal, 100% retention rate. That doesn't happen. You have 1 or 2 withdrawals, one or two dropouts here and there. That's okay, but the target from the outset should be 100%, and we should put in place all these strategies, detailed plan, retention plan, written out at the start of the study to make sure that we maximize retention in our trials. So that brings me to the end of this talk.
Thank you very much, Dr. Kaali, for that very insightful session. I'm particularly impressed by your high retention rate. I mean, clearly, we have to come and take a look at the templates you are using for your, i.e. your retention plans and so on. Okay, great. So as I mentioned, Dr. Kaali will be leaving us shortly because he has another presentation to make in some other conference going on right now. So if there are any burning questions, now would be a good time to indicate by raising your hand. Well, there's another question. I'm not sure if it's specifically for you, Seyram, but he says, this is from Abraham Babu. He says, how would you weigh in on RCTs versus platform trials to enhance retention, especially in LMICs? Question is not very clear to me, but Seyram, if it's clear to you, please go ahead.
Okay, so the participant is asking about how to enhance retention in clinical trials. So that's what we've been talking about. So it's crucial that you go through all these pointers at the start of the study. Try to develop a retention strategy. Understand your local context. You know what it takes to keep participants in a study. You know, you can begin by doing a small survey. You know, among your trial participants. You know, or the your study population, and find out from them what's important to them in terms of what factors do they consider if they want to participate in a study and if they want to remain in a study. And then you will know from your context what's important to your participants. So it helps to set all these things out at the start of the study, and then continuously you know, appraise these strategies and make sure that they work for you in the course of the study.
Yeah, thank you very much, Seyram, for that. I mean, looking at the question again, he appears to be interested in comparing RCTs versus platform trials. I mean, it's still, you know, within the same domain, but I guess perhaps he's interested in how maybe an adaptive platform, you know, due to its complexity and the fact that things change as, you know, the trial evolves, perhaps there could be some considerations anyway. But I think the general principles you have shared will apply generally across trials. So thank you very much. Someone has a question about what scheduling tools you use for your studies.
Okay, yeah. So so some sponsors have vendors like the one I showed in the last but one slide. Or if you don't have such a specialized tool, you can just use Excel and then build a schedule into your calendar, you know, so that you are getting reminders and you're not relying on the PI or the study coordinator's memory to remember when participants are due for their scheduled visits.
Yeah, thank you very much for that. So incidentally, we actually have, in one of our presentations, there is a demonstration of such a scheduling tool based on a spreadsheet. You can use Excel or Google Sheets to do this. So in our last presentation, we will see this. I don't see any other question currently, so maybe I'll ask one of my own before you run away. It is just a point of curiosity for me. The question is a bit broad, so bear with me. I just wanted to find out from the experience of Kintampo Health Research Center, how, you know, as the COVID-19 pandemic evolved, how it affected ongoing studies and even new ones in terms of, you know, recruitment and then the retention rates. Did you have any interesting short-term or medium-term measures you employ that we could learn from?
Yeah, so, you know, during the COVID-19 pandemic, we had some trials that were running at the time. And because we had to limit physical contact, we had to devise virtual ways of reaching out to participants. So post-pandemic, we found that it's useful to combine virtual means as well as physical means of contacting participants. During the pandemic, one topical thing that came up really was the subject of participant compensation. It went all the way to the Ghana Health Service Ethics Committee, which is like our central ethics committee. And post-pandemic, we've been struggling to come back to the baseline, but that shows the need of having a guideline for determining compensation in trials for different phases, for different designs. So that's some of the things that we've experienced during the pandemic and then post-pandemic.
Okay, so thank you very much, Seyram. I really appreciate you spending some time with us, and all the best in your next presentation at the conference. So we'll move on to the next presentation. Third presentation for the day will be taken by Mr. Oscar Bangre, and I'll invite him to start sharing his slides now whilst I introduce him. And his topic will be strategies for community-based participant follow-up. So over the next 15 minutes, we'll hear from Oscar as he speaks to us on this topic. He's an experienced epidemiologist and clinical trial practitioner with several years of involvement in health research projects, including large-scale epidemiological research, clinical trials, data management and analysis projects at the Navrongo Health Research Center, which is also under the Ghana Health Service. He has implemented projects supported by several bilateral and multilateral health agencies, including the USAID, UNDP, the World Bank, and the WHO Special Program for Research and Training in Tropical Diseases. Oscar has also mentored several undergraduates and postgraduates throughout his career. Since November 2022, he's been a lead clinical research coordinator at the Clinical Science Department of the Navrongo Health Research Center. So thank you very much, Mr. Oscar Bangre, for joining us today. The floor is yours, please.
Hello, thank you very much. And I'm very privileged to be part of this session. And I must say that the previous two speakers have already set the tone for my presentation, looking at the definition of what attrition is and the implications of attrition in clinical trials has already been laid out clearly by Dr. Amuasi. And then Dr. Kaali followed on to present extensively some of the factors that result in attrition in clinical trials and some of the strategies. I can say that most of the strategies Dr. Kaali has presented are fairly the same as what pertains in Navrongo Health Research Center, except the contextual differences, which I would hope to be able to present in this presentation. I would look at the context and the sources that are available that we can harness to be able to ensure retention in clinical trials. I would the strategies we at Navrongo achieve effective enrollment and retention in our large-scale and small-scale clinical trials. I would mention a few success stories that go to show how we have been able to have a very high retention. You minimize attrition in clinical trials and then maximize the retention. And then a few recommendations for So looking at the context, the strategies you would map out to be able to ensure high retention would depend on the nature of the settlement you are dealing with. You look at, is it a rural setting? Is it urban setting, or is it a peri-urban setting? In the case where we conduct our clinical trials and where our study participants originate, we also have the Navrongo Center, which is a bit of urban in setting, but that is just a small fraction of the entire study area. So in fashioning out your approach to reach out to your study participants, to follow them up in a timely manner to ensure that you don't lose any, you have to consider the context in which the study participants are drawn. Then you also need to look at the social structure. You would want to look at the education, you want to look at the religion, the values and norms of the community in which you are carrying out your study, skills and your approaches to be able to endear yourself to them in the course of the study so that you minimize attrition. And also, you must be able to know how you can mobilize the resources that are available for you to use to mobilize your study participants. And in mobilizing them, you are also thinking of how to effectively communicate what you plan to do.
Hi, Oscar. If you can hear me, you are breaking up quite a bit, so I think it's a bit difficult to hear you.
Understand what is likely to have a high retention as you proceed. We look at the community level infrastructure and resources that are available. You have a very high retention in your study. So some of the community level infrastructure is looking at the community structure, the hierarchical structure in the community. And then we also look at the numbering, house numbering system that we have built in the community by way of the Navrongo Health and Demographic Surveillance System, where every
Okay, Lois, I think we are having too much interruption of the sound. Lois, I don't know if there's something
every compound is numbered. Yeah. Then
okay.
We also, and with this, we have our study audience and study participants. Okay, let me see.
So, Melvin, Oscar, what I'd suggest is that we share the slides for you. And if that doesn't solve the bandwidth issues, that we just move on to the final presentation. So Jonathan's therefore. So Oscar, I'll just take over screen sharing. Hopefully that will free up a bit of bandwidth your end. And Oscar, if you can hear me, if you can just call next slide. You're currently muted, but if you can unmute yourself and just call next slide, that may be the best option for proceeding. Oscar, you're currently muted.
Yes, I can hear you. Yes, please.
So Oscar, please please go ahead with your presentation if possible.
So what's I had said earlier on is we use the infrastructure that has been built over the years at the community level. And with this, I refer to our health and demographic surveillance system, where every compound or every dwelling structure is registered and all the households are registered. We also take advantage of the community level communication channels that are available to us to ensure that when we are able to reach out to our study participants with effective communication, to ensure that we are able to retain many of them as we proceed. Then we also tap in the enabling community resources, and some of this is the community goodwill and the receptivity. This is as a result of our long-standing relationship with the community and having worked with them throughout, and we have endeared ourselves to them because we have been very honest, we have been very fair to them, and whatever resources are supposed to go to the community, we are able to do it. We have established this rapport and this trust over over 30 years of the Navrongo Research Center working with the community. So they are very receptive when we approach them. So we ensure we build on this. At the community level, if we are having community dinners or gatherings, we rely on some of the linguistic skills of experts within the community to help us relay or communicate our message very effectively. Next. Next.
Louis, can you go? Yes.
Hello. Next, can you?
So we've gone to the next slide.
Okay. Yes. So some of the strategies we have devised to ensure that we achieve very high enrollment and retention, elaborate and very effective consenting. And for us, consenting is not an event, but it's a process. So we have continuous discussion, and as a result of that, the study participants are constantly engaged and they understand their responsibilities and then the responsibilities of the research team in any given study. We also, at the very onset, we ensure that we collect location details of our study participants. And not only do we collect it, but we verify it instantly to be able to confirm that the details that have been provided to us are actually the residential location. And if it is a phone contact that we have collected, we verify it immediately before we put it into our database, so that we are sure that these are functional and these are tangible, that we can follow up and then be able to reach them at a later date. So we also rely on field supervisors who are on motorcycles to be able to do home tracing, to reach out to study participants in periods where we may have difficulty reaching them through the mobile phone. So with all these strategies, we are able to reach out to them regularly. Next. Next. Yes. So with our trials we ensure that we maintain a weekly safety surveillance, and this is done by way of making regular phone calls to study participants and following up, and it's a form of telemedicine. We follow up to find out if they have any adverse events to report. So because of the regularity of this exercise, we are able to tell within the shortest possible time if we are not reaching any participant, and therefore we will trigger the home tracing by motorized field supervisors. We also provide them with a very dedicated and patient-centered medical care, and we are very responsive. If we are even called at midnight and notified of an event in the community involving a study participant, we are able to provide the needed assistance by way of transportation to the nearest health facility for complete and better medical care. And we have been honest with them throughout our dealings. And as a result of that, it has created this kind of trust between us. And when they are dealing with research, Navrongo Health Research Center, they are sure we would work in their interest and we will safeguard any harm that might be occasioned as a result of the study. So we also rely on community debates and community meetings to provide regular feedback on work that we do and the trials that we conduct. If we have results, we are able to feed back to them, and as a result of that, they are updated on the progress of work that we are doing at the Navrongo Research Center. And this goes a long way to let them be partners in the research that we conduct, because they feel part of it from the very onset till the end of it. And if there are any findings or if there are any benefits that are supposed to go to them by way of being the site that participated in the study, we ensure that they receive it regularly and then promptly. Next slide. So some of the examples of very successful trials that were carried out, and I'm talking of trials that lasted, the first one lasted for 5 years, and a total population of about 1,200 participants. And at the end of the study, we were able to achieve a retention of 98%. Then that particular study, when the study ended, 5 years after that study, we followed up this cohort. So that means from study initiation, that was 10 years later, we followed up this cohort and we were able to achieve a 90%, over 90% retention. And this was the study that led to the licensure and an authorization for use of the MEN-Afrivac, that is the meningitis vaccine that has been, and this is included into the EPI in Ghana and then across the meningitis belt in sub-Saharan Africa. We also conducted this clinical trial on a COVID-19 trial with a total enrollment of more over the 2-year period of the primary phase. We achieved 96% retention, and this product was proven. We transitioned to a crossover and a booster phase, and at that, we also had a retention of 90% of the study participants. We also carried out the Lassa fever trial, vaccine trial, which was a 1-year duration, and were able to achieve 100% retention, which is not indicated in this slide. So all this was feasible because of the strategies that we put in place to be able to let the study participants understand what they are going into, and then also the relationship we've had with them, ensuring that they continue to rely on us for further advice and further guidance. Next. Next slide, please. Yes. So in all this, we still encounter challenges. And some of the challenges include cross-border migration and then mobile connectivity blackouts at some times or at some locations. And what we are able to do is to reach out, because all the compounds in the demographic surveillance area are numbered and zoned. So when we obtain their precise location details, we are able to reach out to them via motorized field supervisors. We also encounter seasonal migration, and then those who are migrating out of the study area may provide inaccurate destination details. So we rely solely on mobile phone connectivity to reach them. And even if they had traveled without informing us, and when they are out of the study area and we try to reach them, we can't reach them, we visit their homes and we are able to obtain information as to where they have been able to, they are located now. And as a result of that, if it requires us to even use the family channels to reach out to them, we are able to do so. We also have community level stresses that we have to find ways of overcoming. And this is the disinformation or deliberate misinformation that sometimes is put out in social media. So the scaremongering by those who are anti-science is one challenge, because most of these study participants may not verify the veracity of what is in social media to take their decision. So as soon as we get wind of this, then we see it as an opportunity to dispel or to disabuse their minds of this misinformation. We also have cultural inhibitions that we are well aware of. And as a result of that, we are able to find a way around it. For instance, if a study participant unfortunately passes, due to cultural inhibitions, they may not want to disclose that over the phone. But if we call and then they indicate that the person has traveled, even though the person might have passed, and on 2 occasions, we make a follow-up to go and then find out where the person might have gone to. And when you meet them face to face, they are able to tell you this was the incident that occurred, but they couldn't have said so over the phone. So these inhibitions are sometimes challenges, but we've been able to find a way of going around it. One other thing too is if you do not have very good financing to take care of retention, then you may have this difficulty, because if the budgetary provisions did not make allowance for you to be able to follow up study participants beyond your catchment area, then it may become a challenge, especially if you have some of the participants who have relocated and are willing to return to study site, but because of budgetary constraints, you are unable to support them to return. Then we also have the study staff being proactive, and also the conduct of the study staff being something that can put off some study participants, and as a result of that, you can have attrition. And as a result of that, in our recruitment of study personnel, especially those who would interface with study participants and the community, we ensure that we inculcate into them this participant sensitivity, so that they are able to give the participants the utmost respect, and then they would be able to be very professional in dealing with the participants, so that they would feel they are most welcome and they are well received in the study, and that would encourage them to continue to participate in the study. Next slide. Yes, so to be able to overcome these challenges and ensure a very high retention in clinical trial participants, you would need to develop a well thought through participant enrollment and retention plan, which we regularly do for every study. We look at the factors that are likely to affect retention, and then we include that in the retention plan, and we train all the personnel on how to ensure that this plan is executed perfectly to achieve high retention. We also have extensive and key stakeholder and community engagement before, during, and after the study. So the community gets well informed about whatever trials we are carrying out, and as a result of that, we are able to retain a very high chunk of our study participants. And as I indicated earlier on, in the training of our study personnel, we inculcate in them an enduring ethical and culturally appropriate values, so that in interacting with the community, interacting with study participants, they are minded that they need to be very ethical, they need to be culturally sensitive, and they need to treat all study participants with utmost respect, because they are the ones who are providing us with a job. So it's incumbent on us to make sure that we respect them and make them the center of all what we do. We also regularly review the retention strategy using what our strengths are, what our weaknesses are, and then we also look at the opportunities and then the threats, and we make sure that these go into our enrollment and retention plan, so that we can continue to have very high enrollment and retention. Then we also develop an effective and responsive crisis communication plan for prompt deployment to diffuse any vile rumor and misinformation. This is very, very critical, because if your crisis communication plan is not in place, and there is a rumor and you are not able to target it well, you would see that your participants would exit the study in droves. So for every study, we look at what the study duration is, and we put in the structures to be able to rapidly address any crisis resulting from misinformation. It could be a pandemic, it could be any unforeseen event. So to be able to ensure that you continue to retain a high number of your study participants, you should have this as a tool that you can use to address issues that may lead to very high retention, attrition. Next. Next slide, please. Yes. So with this, we at Navrongo Health Research Center, we are able to usually focus looking at what the likely push factors can be for study participants to exit. Then we try to devise the strategies to ensure that we counter those before they even set in. So this is, in brief, this is what we are able to do at the Navrongo Health Research Center to ensure we have very high retention. Thank you very much for your attention.
Thank you very much for that wonderful presentation, Oscar. Really enjoyed it. We hope to have some more discussions on that when we come to the Q&A session. So in the interest of time, we'll go straight to the next and final presentation. I'll encourage all who have questions to put them in the Q&A section so that Oscar will speak to them now. But Jonathan Gmanyami, our next presenter, is our call center and field supervisor here at the Global Health and Infectious Disease Research Group at KCCR. He holds a bachelor's degree in public health and a master's degree in applied epidemiology. Prior to his current role, he held positions as teaching assistant at the School of Public Health and later a research assistant at the Institute of Health Research, both at the University of Health and Allied Sciences. Currently, Jonathan is a recipient of the German West Africa Center for Global Health and Pandemic Prevention Scholarship and a PhD candidate at the Kwame Nkrumah University of Science and Technology. His expertise spans both field epidemiologic and clinical studies, including clinical trials. His presentation today is a case study of a call center used to support clinical research operations here at KCCR. Thank you for joining us, Jonathan. Over to you.
Thank you very much, Dr. Melvin, for the kind introduction. And I must say that the earlier presenters have really laid a very strong foundation, Dr. Amuasi, Dr. Kaali, and Sir Oscar, and I will build from there. So I'll be sharing on a case study, a clinical research call center we have at the Global Health and Infectious Disease Research Group here at KCCR in the beautiful city of Kumasi. So for the next 10 to 15 minutes, this is going to be my outline of presentation. By way of background, in the heat of the COVID-19 pandemic, the Global Health and Infectious Disease Research Group, in collaboration with the Infectious Diseases Epidemiology Research Group, established the call center, which was dedicated to remote follow-up of clinical research participants. Remarkably, this initiative was implemented without relying on any sophisticated equipment or any custom service. And this clearly demonstrates that as a research group, we are committed to innovation and adaptability in ensuring that participants are continually engaged. For our staff profile, we are a dedicated team of well-trained professionals. Our call center coordinator, a clinician researcher, leads the overall operations of the center. And I am the call center supervisor. I supervise the day-to-day activities of the center. We have the physician assistants and steady nurses, and they actually conduct the follow-up calls and address any medical concerns that the participants may have. Similarly, our research assistants help in populating the scheduler. In a later slide, I will demonstrate how our scheduler looks like. And the scheduler is a tool that we use to remind and schedule study participants for their study visits. I will touch on a few selected projects where we implemented the call center. Currently, we have the Sanofi vaccine trial on, and through the call center, we monitor the CLI to mean COVID-19-like illness through active and passive surveillance calls. Active calls are calls that we place to the study participants, and passive surveillance calls are the calls where they rather call in. So our study participants on VAT, we contact them once every week, and this has been done over 2 years to inquire about the development of any signs of COVID-19, and also to remind them to always contact us if they experience any signs of COVID-19. Similarly, we operationalized the call center on the anti-cough trial. The anti-cough trial is an open label, randomized, adaptive platform trial. And concurrently, as the anti-cough was ongoing, we had two auxiliary studies, which is the epidemiological study and the immunological study. And for all these three studies, the call center played a very key role in reminding and scheduling the study participants. For the epidemiological study, we literally called them every day for 1 month, same for the master clinical trial. Similarly, we operated the call center on the CLARE, which is an observational study of COVID-19-like respiratory pathogens. By way of history, the call center was established in June 2021, and so far we've successfully engaged a total of 1,391 study participants who have accepted phone follow-up as part of our research efforts. Since its inception, the call center has placed over 78,000 calls. And these calls are successful calls that we called and we literally spoke with them. And the majority of these calls are related to the VAT trial. Most of these calls are outbound calls. I can confidently say that for some of our study participants, they've heard from us via phone call more than their relatives or their partners, because we literally call them once every week. As at last year, we had a 15 staff team, out of which 10 were females, and we have 5 as males, of which I'm a part. The call center operations. Our call center plays a vital role in supporting our research activities through several key functions, and I want to touch on 3 because of time. We specialize in scheduling of study participants. In an urban setting like Amuasi, where we are, everyone is economically busy, and hence consistently reminding these participants of their study visit is key to minimize missed appointments. We actively remind the study participants at least 2 times, which is a day before their due visit and 2 to 3 days before their due visits. However, there have been times where, despite our efforts to remind them, there are some who still miss their due visit. So depending on the study we are on, the protocol allows a window period. So within the window period, we still push to remind them, and this have worked effectively for them to still come for their study visits. For surveillance calls for data collection, we do conduct active and passive surveillance calls to collect data. Our call center has faced some challenges. Occasionally, some participants struggle to accurately describe signs and symptoms over the phone. There have been logistical issues, phone network issues, internet challenges here and there, and light out in our setting, we call it doomsor. And these occasionally have led to breaks in communication. Though rare, equipment sometimes malfunction temporarily. However, as we speak, we have a backup of all our equipment, so that is not a current issue at all. But one of the most common challenge is that participants sometimes feel tired hearing from us every week. So for those on the vaccine trial, they've literally heard from us every week for the past 2 years. To effectively manage the risks associated with our call center operations, we have implemented several key strategies. We have established SOPs and SSPs, site-specific procedures and standard operating procedures that ensure that our processes are standardized and consistently followed. Our staff continually go through regular trainings with the help of our coordinator. There's always continual oversight, which is provided to monitor performance, and any issue that is identified is always rectified real quick. We engage in logistic planning, and this helps to not only anticipate, but mitigate potential challenges. In the next slide, I'll be demonstrating how our Google spreadsheet-based tool looks like and how we operate it in scheduling our study participants. Thank you very much for staying with me till now. So this is going to be the demonstration video of what we do at the call center and how we are able to do what we do. So this is an example of a Google spreadsheet. The reason for a Google spreadsheet is to give access to other staff who are equally working on this scheduler. So we call a Google spreadsheet the scheduler. So depending on one's role on the delegation log, that will inform us whether to give the person an editing access or just a viewer access. So for the purpose of this demonstration, we will have a study that requires that study participants come to the study, to the site just twice, which is on the day they are recruited, and on the day 7th, which is 6 days from when they come. So maybe we can just insert the formula right here. So the due date, which is day 2, because with the day 1, it is when the people are recruited onto the study. So the due date, which is day 7, the formula will be is equal to day 1 plus 6. The reminder, so what we do is that we remind the study participants when they are supposed to come to the study site per the protocol we are working with. So for reminder 2, we want to remind them a day before they come. So it will be day 1 plus day 5. Then this is day 1 plus day 4. So depending on the number of study participants, we drag the formula to apply for all these cells. Just as you can see. So we have participants 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, depending on the number of study participants you are working with. So let's assume that participant 1 was recruited onto the study on the 18th of August, 2024. So automatically, we are able to easily tell that this participant, we will call him on the 22nd of August, that he's due on the 24th. On the 23rd, we let him know that he's due the very next day. Then on the 24th, we get to know. So practically, using our Sanofi trial where we have over 500 study participants, it becomes very difficult to be able to track when each of them is coming, owing to the fact that they were recruited on different dates. So we can drag this. So assuming that participant 3 was recruited on the 20th, participant 7 on the 24th, how will you be able to tell who is due when? So to make this easy, we have to employ legends. How do we do this? We want to see colors. Colors will help us easily track who is due. So for us to be reminded, we can choose any color at all. Let's go with yellow. For a due date, we can go with a blue. So the next thing, the reason for this column, the actual visit date, is extremely very important because sometimes the study participants are not able to come when they are due. And per the protocol, assuming that there is a visit 3, the protocol can say that visit 3 is 6 days from when the participants actually came and not necessarily when they were due to come. So this column is extremely very important. So when you right click on this column, you go to the conditional formatting. And the format rule is that, so format cells if it is equal to what? So you put the is equal to sign there. If it is equal to today, we open bracket and close. So what should happen today is that it should turn yellow. Why yellow? Because we are working with reminder. Reminder 2, we do same. Conditional formatting should be equal to today. Bracket open and close. Why are we saying today? Because any day becomes today when you open the scheduler. So the color for reminder 2 is equally yellow because of the legend we are working with. Then for the due, the conditional formatting, same formula is equal to today, bracket open and close. We are working with blue. So on a typical working day, when we open the spreadsheet, clearly we are able to tell that participant 4 is due a visit today. Participant 5, we are to remind the person that he or she is coming on the 28th. For participant 6, we are to remind the person that you are coming on the 29th. So we can decide to change. So let's assume this person is to come on the 21st. Should we drag so that it applies to all the cells? Automatically, we see that the colors readjust. This helps us to notify the other team members, the logisticians, the lab, so that we can equally and adequately prepare for the coming of these study participants. Thank you very much. We'll move to the next slide. Thank you very much. I would want to add that participant confidentiality is extremely very important. And with this in mind, we do not have any identifying information on the spreadsheets. We have a very heavy protected paper-based enrollment logs, and these enrollment logs contain their contact details, and we refer to these logs when we are placing the phone calls. Over the years, I would want to touch on 6 lessons because of time. The call center has been very effective in operationalizing our study designs. It's an avenue for data collection. It helps to facilitate the identification of adverse events. The call center provides that avenue for a feedback loop, which helps to improve the study. It's through the call center, especially because physician assistants and study nurses place the phone call, we are able to make referrals and also to give first aids. And also, I think Sir Oscar did mention that as we call them again and again, the study participants build trust in us, and this helps to retain them in the study over the years. In conclusion, our experience with the remote phone follow-up shows that it is a practical approach that can be effectively implemented. Also, the high level of participation engagement indicates that this method is well received and can successfully maintain their involvement over time. The call center potentially enhances safety, not just for the study participants, but also for us, the researchers, especially in the context of infectious disease research. Thank you so much for your time. So for us at the Global Health and Infectious Disease Group, we are available. If you want any more details on the scheduler and its design, you can always reach out to us. Thank you.
Thank you very much, Jonathan, for a very wonderful session. And as Jonathan mentioned, we are available for further collaborations if you want further clarification, some training, or indeed, if you want to teach us something, we are also happy to learn. So please reach out to us. We'll put our links in the chat and then the Q&A session. You can find us if you look for us, and then you can continue the discussion. So we also want to thank you for sticking with us to the very end. We plan to do this in 1.5 hours, but we've done for now 1 hour and about 52 minutes. So 22 minutes above time. Because of this, we will not be doing a very long Q&A session. But at this point, the floor is open. If you want to speak, just raise your hand. We will allow you to speak. If you want to type your question, please do not use the regular chat. Kindly post it in the Q&A session so that one of the panelists can attend to it. Maybe I'll throw at Oscar first because it has to do with something about remoteness of participants. So the question is about participants who tend to relocate to other places or maybe in locations where they are a bit remote. And given that you do a lot of community-based follow-up, we want to understand how you work around the difficulties in tracking such kinds of participants. This is a question from Ezekiel.
Yeah, thank you very much. So as I indicated, once you enroll participants, especially for studies that are of a longer duration, you definitely have participants who may travel out of the study area. So because of how frequently we reach out to them, we are able to detect if they have traveled out, because on a home visit, you will be able to obtain information as to where exactly they have gone to. And if possible, if they have a new contact, they will definitely want to be in contact with their family or their relations. So we take advantage of the home visit to collect this information. And through that, we are able to reach them. Sometimes we may even require that a family member arranges for us to talk to the study participant if he or she hasn't got a contact at his new location, but a family member who is resident there is able to facilitate that. So we do so, and sometimes if they go across the border, in the instance of those who farm across the Ghana-Burkina border, we are able to use the family contacts to trace to their locations in those areas, because when they go across, then the telephone network may not function. But when we reach out to their family who know where they stay, we are able to reach out to them. And that is how we are able to ensure that we don't have many, or we don't have a high rate of loss to follow up. Thank you.
Thank you very much, Oscar. Anthony Hammer, your hand is up. Kindly unmute and then ask your question.
Yes, thank you very much. My question or my comment, excuse me, is in relation to the last presenter's SL demonstration. That's Jonathan. I just want to add that, well, it's best to create a dashboard so that when they click on it on a day, they're able to see the key metrics. I mean, the number of people who are required to come for a clinic visit, or those that must be reminded of next visit. So I just want to chip in that creation of a dashboard helps people who are not conversant or who are not familiar or who do not want to see plenty data. You know, we can hide the dashboard, will hide all those things, and they can just deal with the dashboard. Thank you very much.
Yes, thank you very much. Before Jonathan comes in, I'd just like to say that, yeah, we do operate dashboards for several of our studies. We chose, in the interest of time, to demonstrate just one tool, and also because the spreadsheets are quite ubiquitous and cheap, and most people cannot build dashboards, to be very honest. But yeah, I mean, it really is a one way to make things very, very easy. Jonathan, I don't know if you want to add something.
Oh, actually, thank you for the question or the comment. Actually, I've aired my thoughts, so I'm actually wanted to say same. Thank you very much.
All right. Thank you very much, and thank you very much, Anthony, for the comments. I think maybe in our next one we would show other things like this as well. Okay. Let me see which other question there may be at this time. Just a second. And there's a question about how is the visit scheduled in the call center? I think, Jonathan, this is probably for you. How are you able to tell participants who missed their visit? do you record anywhere once you contact a participant? Jonathan?
Yes, thank you for the question. Exactly, we do. So we have a phone tracker, which is paper-based, and we always record the outcome of the calls. So when a participant is called and it is successful, depending on whether the person will come or not, it is recorded. And it is by that recording that we are able to notify the other team members concerning the number of study participants that should be expected at each study site. However, for those who are not able to come, as I aforementioned, we are given a window period per the study protocol we are working with. And by that, we are able to keep calling them to ensure that they come for their study visits.
Yeah, thank you very much, Jonathan. That was very good. I have a question I saved earlier on. Maybe I'll pass over to Dr. Amuasi. And I mean, the essence, I'm just paraphrasing the question. The essence is that patients are not required to explain why they are exiting the study when there's, events that they want to withdraw from the study. But of course, as researchers, we also want to know why they are exiting. Although per GCP, they don't need to give you any reason. But I think we will agree that if we have this information, it helps because there may be some systematic issues that we could address within the study that will minimize participant loss. So I think the question really is about how you manage these seemingly conflicting, perspectives to sort of minimize the problem of attrition.
No, thanks for that, Melvin. I believe that you're very well placed to answer this. Nonetheless, since you've asked me to, I mean, I would say that, it's always a balance. And if you realize when you unsubscribe from various mailing lists, even by email, you are presented often with a bunch of options to inform your departure, or even a text box where you may type in the reasons for your departure. The objective is just so there can be an understanding which would inform further action. So we will ask for reasons, but it is not a requirement. We will not deny the person exit if they don't provide a reason. So I would say it is good practice and in the interest of everyone for the reason for departure or discontinuation of a study participant to be known, but this should by no means be a prerequisite for exit to be approved, or should the participant feel under pressure to disclose the reason for their departure. So that's what I would say. It's a valuable piece of information.
Yeah, thank you very much, Dr. Amuasi, for that response. I think we would not be able to take further questions or comments at this point, even though we would like to go on and on. I see more hands are going up. But in the interest of time, we've already done more than 30 minutes above what we expected. So we would like to show our appreciation to the audience for taking part in this webinar and to our distinguished panelists for sparing us some time today, and to the organizing and technical teams. You've been amazing. Thank you very much for the excellent effort. As we noted earlier, the recordings and any additional materials will be shared. You'll find a link in the Q&A or the current chat. So please grab these before we close the session. So we'll leave the link open for about a minute or two. As you get a link, then the meeting will end. We will also send you the webinar evaluation form to the email you use for registration. Please complete the evaluation. It's very important to us to let us know how to improve. So thank you all very much for this wonderful session. It will certainly not be the last, and we would come into your emails before soon. Okay, bye for now.